Good afternoon, everybody. Good afternoon. Can you guys hear me well? Great. I love the buzz and energy. So my name is Kapama Yalpala. I go by KP. I'm a senior fellow and lecturer at the School of Public Health and lead our innovation initiative there. I also am the lead for the health track for our Innovation Summit. I'm really excited about this collaboration with Yale New Haven Health. As some of you know, like how many of you were at the Health AI Symposium yesterday? Wonderful. So we're so happy to have you here today. We've really wanted to create more integration between the Innovation Summit and the symposium. And as you know, there are some wonderful pitches. We want to build on that momentum. So I'm going to introduce Dr. Margaret Cartiera, who's our moderator for today. And then I think you should be in for a great session. So Dr. Margaret Cartiera is the venture advisor and lead for strategy and new initiatives at Sci-City. And she also is the director at the Center for Healthcare Innovation. She's been working in the innovation space for many years herself, but also is one of the people that has been tremendously supportive of entrepreneurs and innovators here in our ecosystem. So no better person to moderate this panel. So over to you.
Thank you, KP, for that really kind introduction. We are also really excited about the partnership between Yale New Haven Health, Yale, and the two different conferences that we're having. And this discussion today is going to be building on the conversation yesterday. In yesterday's conversation, we were really highlighting and unpacking a lot of the issues around AI in healthcare, trust and safety, governance and accountability, and integration. Today we want to unpack a little bit more, specifically information around how do you really integrate? What's the real world journey of taking an AI algorithm from concept to integration, implementation. And we'll hear from two of our Silver Award winners from last year's 2025 AI Symposium, and hear a little bit more about their story. I'd like to have each of the panelists introduce themselves and say a little bit about how your health system is either working on AI review, or if you're an innovator, what your innovation is and what you're looking to achieve.
Hi, everyone. It's a pleasure to be back here, and thanks for YNHH and Innovation Summit for putting this together. I'm Rohan Kira. I'm a general cardiologist and data scientist at the Yale School of Medicine. I direct the Cardiovascular Data Science Lab. And we do many things that are adjacent to AI or its implementation, but the thing that we're very proud of is using existing data systems, like data that is generated as part of healthcare encounters by patients, as part of their going in and out of our systems, and the simplest and the most widely available data systems to arm us to diagnose diseases before they clinically manifest several years later. And a great example of those are structural and functional disorders of the heart that often result in heart failure, premature death. And our biggest challenge has been how to pick up these people when their disease is reversible and has therapies that can modify the course. And we build solutions that deploy lightweight AI tools to electrocardiograms, just stickers on your chest, no radiation. And we do about 200,000 of those studies in our own health systems each year, and about 300 million across the world, from the smallest clinic to the biggest health systems. So we have tried to find the big unifier by using the most widely accessible data systems and building them together in a way that we can diagnose conditions that require advanced testing routinely. So that's our goal, and I'm sure we'll talk more about it.
Hello, everyone. My name is Richa Sharma. I'm a stroke neurologist here at Yale, working in the hospital as well as in our outpatient clinic setting. My solution is called Polaris, which is a clinical decision support tool to help physicians and non-physician clinicians improve their quality of care for stroke patients while they're in the hospital, so that those patients don't go on to have another stroke.
Hi, I'm Dr. Lee Schwam. I'm the Chief Digital Health Officer for the health system, and I'm an Associate Dean for Digital Strategy and Transformation at the School of Medicine. And I think the comment that I would make is I'm very focused on thinking not in the traditional way of point solutions versus platforms, but at the solution level. We want to build platforms that can enable the kind of innovation that these two amazing innovators have brought forward, so that we create repurposable containers. So the next innovation that comes along is just drop and integrate. Now, there's a tremendous amount of work that goes into understanding the workflow, not just the data source and the diagnosis, but then the workflow and how you ingest and also output that information. And again, if we can define standard modularized channels for that. Oh, it's a direct-to-patient message. No, it's a direct-to-provider message. No, it's populating a consult list for somebody. I think we can generate innovation at scale without an exponential increase in cost.
Hi, everybody. Good afternoon. Adam Landman. I'm an emergency physician and the Chief Digital Information Officer at Brown University Health in Rhode Island. Also a proud Yale alumni. It's great to be back here. And really excited to see what all of you have done, and with Lee's leadership, what you've achieved with the Health AI Symposium, and see the incredible innovation that you've been able to accelerate. I'll take a more general approach and sort of say, from my vantage point, I think, and if we look what's common across healthcare, we are at sort of a moment in time, right, where there are critical forces affecting healthcare delivery and causing challenges for all of us, right? The first is access to care, right? It's taking a huge amount of time to get a primary care physician or see a specialist. The second is financial. Many organizations are in the red, struggling to survive, right? That's real. Hospitals are closing. Ambulatory practices are closing. And third is provider burnout. We are seeing administrative burden increase, leading to high amounts of burnout, and we are seeing physicians, nurses, and others leave the practice of medicine. So these are huge challenges we're facing, and where I see the opportunity for technology, digital innovations, as well as AI, is in addressing those. And I think the key is, as you're getting to know an organization, it's sort of like dating. Right, you've got to understand, I gave you the general challenges we're all facing. You got to really zero in and figure out, what is that organization facing? What are their key challenges? What's their problem to solve that's a priority for them? And if you can solve that with your solution and add value to one of those bigger themes, then you've got a match and a fit to innovate together. And I think that's what we can all achieve.
Thank you.
What he said.
So maybe we can talk a little bit more contextually, Adam, if you could share, when you engage with early stage innovators, what do they struggle with in terms of algorithm development and engaging with the health system? So you mentioned understanding needs, et cetera, but in specific, when we're in the AI space, what do you find are the greatest challenges when you engage with them?
Excellent question. I would say, number one is the fit. Is there an actual need in the health system and a priority that's been prioritized by the leadership that the solution's going to solve? Many come with really impressive innovations, and you've spent a lot of time validating them and showing that they work. I would say there are maybe 2 or 3 areas that I think are often a struggle. The first is the last mile. So you've got your algorithm, but have you thought about where you're going to get the data from? How is it, is it going to, or how is it going to integrate with the electronic health record? Then more specifically, how will it work in the workflow for the clinicians or other users that are going to use it? And what are sort of the change management components of that innovation? I'd say the second thing is actually validation. While I'd say that you've all done your validations, you've done it on a certain population, that population may not be appropriate for the organization that you're talking with. And so it's very possible, and you should frankly expect, that you might have to validate again with a population that is specific to that organization. Further, that may also help improve trust in the end users, particularly the clinicians who will want to be very evidence-based. And then the third component is around sustainability, right? And the question is, you've got this great algorithm, and I find this particularly with internal innovators. You've come up with an incredible solution. Maybe it meets a need, but how do we make it sustainable? Have you thought about how much is it going to cost? Where are we going to come up with the funds for it? Is there a positive return on investment? Also, who's going to support it, right? The algorithm. Who's going to monitor it over time, making sure it's not drifting and making updates. So you quickly see that an incredible innovation, this incredible algorithm that's been worked on, validated, maybe published on, still has a number of steps that need to be addressed before it's really ready to scale across a health system.
Thank you. Lee, yesterday we talked quite a bit about the AI governance process and the review process, risk mitigation, return on investment, and value. When you think about the different algorithms and innovations coming into a health system, how do you think about innovation speed without compromising patient safety and institutional trust? So how do health systems approach that?
Yeah, this is where I strive to be the Rebel Alliance and not the Death Star. Because it is so easy to just put up a series of gates that just make it impossible for inventors and innovators. And I think, these two people next to me, you'll hear their story in a minute, they've been very patient, but I think we have also surfaced through our governance process review and through our workflow reviews things that were unanticipated that needed to be dealt with. And in some cases, things that weren't anticipated, could have been anticipated, but it's like, okay, I'm just going to put a pool in the backyard. Well, actually, it takes a lot to put a pool in your backyard. Like, you can say that, but you got to get someone to come and survey and dig and then get the water and there's a lot of stuff there. So we spent several months building the container that will house these algorithms. That's nothing the inventor would have known did or didn't exist beforehand. So some of this stuff is just the necessary part of being the first one in, right? When you're the first in, as the innovator, you're plowing the road for everybody else. The next innovator gets to hop on that train much faster. We started our AI governance model. By the way, it's a digital governance model. It's not an AI governance model. It sits on top of our digital intake and review process. If you have an AI component, it gets flagged, and it goes for a heightened level of scrutiny. We started, and I thought we would have 5 or 6 work streams that would review these. I think we have 13 now. Because every time you have a conversation, something gets raised, and someone is like, hey, I think it would have been really helpful if I had heard about that at the beginning, not at the end when things were fully baked. So compliance, billing compliance, I didn't think that we needed both of those, but it turns out you really do. We needed legal representation both from the health system and the university, because a lot of these, especially the internal innovations, are being created by Yale faculty, but also Yale faculty practice in the health system, and so inevitably both of those parties get engaged. I think that the most important thing we did was we created a risk proportionate model, meaning we spend the most amount of energy on the things that are the highest risk, and we are developing a fast lane for things that are very low risk or have very low tech AI, like very baseline robotic process automation, or NLP. I think where we will struggle, we've been doing this for I think maybe 5-6 months. We've reviewed 40 applications, and we have another 15, I think, or so in the hopper. We're making progress, but we will soon be flooded, right? Because 20% of our applications, 10 to 20% had AI when we inventoried them 6 months or a year ago. It'll be 40%, and then it'll be 70%, and then it'll be 90%. There'll be almost nothing that doesn't have some piece of AI in it. So how do we create flow through this process? Like you say, deal flow. How do we create process flow? Imagine if in the emergency room everyone got a 15-hour actual workup, not got a 1-hour workup and then 15 hours of waiting. But if they took 15, you'd shut down, right? You wouldn't have enough capacity to see all the people who need to be seen. So we need more of that triage mentality, and really divert the low risk cases to a very light touch, and then really focus on the high risk ones. The last thing I'll say is post deployment monitoring is like the complete quicksand pit, because we don't really know how to do it. We don't do it well in healthcare to begin with. A lot of that responsibility shifts to the digital team when it's a digital solution that is now being implemented, whereas before it was just a manual solution. So how to get sustained engagement with the end users and to deployers, who are the ones who are best situated to tell us if the thing is working or not, and feed that back in centrally, that's a process.
So That's really great perspective in understanding how health systems approach it when others engage with them. And I'm sure you all now want to know the gory details of now what happens when an internal innovator takes their algorithm forward. I think it would be helpful to first understand, as innovators, faculty members who are working on big problems that you've identified, at what point did you know that this was more than a concept and that you wanted to move it forward in terms of something that would have clinical impact?
Okay.
When you were born. No.
In particular, with this innovation, when did you know it was time to scale it?
Great. So I think I knew it needed to be scaled at the time of idea crystallization, which actually happened with my mentor in his office when I was a fellow, Dr. Schwam. But the impetus was that there are a bucket of patients with ischemic strokes who, despite workup, fall into a category called cryptogenic, meaning they've had the $1 million workup and no one still can tell us why they had their stroke. And the reason why that's so frustrating, it was frustrating to me as a stroke clinician, was because if you don't have a diagnosis, it's very hard to administer proven evidence-based targeted therapies so that the patient can not have another stroke. And so I saw this as a multimodal problem that I thought machine learning could tackle, because as a clinician, as a human clinician, I am fed data from multiple sources before I can synthesize those data points to come up with an inference of a diagnosis. So it's a multimodal data problem and an inference problem. And so I figured, there has to be a better way than running over to our expert stroke neurologist with this vast amount of data to crystallize the diagnosis. And so while I had that problem at a quaternary hospital with a multitude of stroke neurologists, I could only imagine the plight of the hospitalists working in rural Indiana with a fraction of those resources in trying to make that diagnosis and properly implement the secondary stroke prevention care that research scientists have really honed so well over the course of the past 2 decades. And so that was the reason why I felt like there could be a better solution. And so that led me down this path of collecting data sets, very patient by patient, reviewing all the records for up to 3,000 patients from 3 different hospitals, getting consensus on that diagnosis for each patient of why they had the stroke, because unlike a heart attack, strokes can be due to multiple reasons: atherosclerosis of the neck arteries, a rhythm called atrial fibrillation, small vessel disease, dissection. There are a multitude of possible etiologies of stroke. And so,
Risha, maybe you can jump in. As you were working on this problem, and now you're collaborating with the health system in terms of integration, were there any surprises as you were integrating in terms of where you started and then where you were going?
Totally. I think the algorithm derivation and validation was the easy part. Publishing your findings, I didn't want them to be siloed in a publication. That was my worst case scenario. And so the next piece was the integration. And honestly, the impetus to be able to integrate, to have the permission of the health system to take me on as a project, only came from the seed funding and the recognition that I was able to achieve from the Health AI Symposium Award. Before that, there was no pathway forward. And so once that happened, I felt like I received a huge amount of support from the health system. And that included the digital and technological solutions team that is a really crucial umbrella at YNHH, who partnered with me over the course of the past 10 months or so in really taking me through all those steps of integration that I could not even conceive before I started working with them. And so what I learned was every step of the integration process requires extreme amount of understanding the, sort of the landscape, what my options were, then testing those options, validating which one would really get me to the endpoint that I'm looking for, which is a tool that a clinician could easily use, that's not intrusive, that can help them with the workflow and optimize their practice.
Thank you for sharing those insights in terms of how you moved it forward. Rohan, could you tell us a little bit more about where you started and where you ended? What jumped out at you in terms of most surprising in that journey, and maybe some of the supports that you received along the way?
I think the journey is like a little convoluted, like every single one of them. Our lab started working 6 years ago on deploying AI in health systems, and our initial work was around natural language processing before GPT was around. So it kind of gave us a sense of how EHRs are built, how to leverage text and build cohort structures. And we recognized early on that some of those deployments that we were working on deep learning processes could be deployed more widely on diagnostic tests that were being done at that point, like ECGs, like imaging, that could then be integrated back into the health systems for enhancing disease diagnosis. So now we've built a stream that takes EHR data, language, ECGs, echoes, everything, and builds a cohesive story. And we started also this, and again, Yale Innovation Summit, I'm not new to this is my third or fourth one now. And I've been here like as an inventor before, and the idea that it's a product is important to have, because that's the lens with which I now communicate with the leadership in our health system and university. Because it cannot be a concept. It has to be something that people can put a finger on. Okay, this is a tool that takes this kind of data, does this process on the data, spits this output. This is the performance of the output in our population, and what should be the downstream workflow that follows. The development and validation, as Richa pointed out, are the easy parts. We could do it here. We could have a few partner sites, send our model over. They could deploy in their siloed data, and it was okay. And now, that stuff can be a very high-impact publication, and that could be the end of the story. We spun out, but for us, it didn't sort of work that way. So we wanted to really make sure this was a tool people could use in practice. So with support from Yale Ventures, and Bavatnik Fund, we spun out Insight AI that allowed us to sort of take our tools to the FDA, receive a breakthrough device designation. We have decided not to sort of seek a very heavy funding so that our tools can remain economical in the eventual use case. So a few pharma partners are helping us push through the FDA. But the biggest challenge was that would just be the tool for its explicit performance. The same stuff we did for the manuscript will become the tool's FDA clearance. Has nothing to do with deployment. The world is full with a graveyard of FDA-cleared AI products. And that we didn't want to join that. And I think that's where the Health AI Symposium and Championship was so important, as was the Precision Medicine project from the Yale University School of Medicine, because both of them together gave us the resources to think about this as a holistic health system challenge. I could take electrocardiogram, deploy AI, and find who has cardiac amyloidosis or who has a structural heart disease. But I didn't know what to sort of who would be the one whose ECG would be scanned? Which provider would be informed about the information? What would be the downstream workflow? How am I ensuring that it's ethically deployed and it's not deployed and it's not exacerbating disparities among people who just got the first test that others didn't get? How do we ensure that it's consistent, persistent, deployed, that we have as Lee pointed out, the infrastructure that if we went from 1 model to 5, the system can absorb that and can still sort of become the seed of innovation. And I think that's what's happened in the last sort of 8 to 10 months. And what's been sort of both fun and challenging is things that seemed challenging, like creating a clinical work group, became much easier. Navigating the ethical work groups were more challenging because, you didn't know who to ask, what instrument to use, what is the tooling. On the health system side, we were getting ECG data for developing the tools, but then the same pipeline wasn't the one you could leverage to sort of deploy, because it had to be an application that was not going to break the clinical workflow, but still be robust enough to run real time and spit the results back into the EHR. And then we are now running a bunch of A/B testing platforms of where do we report this result, in the ECG report or in the EHR as an assay result. When all these things are being tested, do we alert the clinician, or do we have a running dashboard of people who screen positive that we review intermittently? And all of these things are going to be the things that differentiate good innovations from great ones that change care of patients.
I really appreciate the framing of this isn't a project, this is a product that will be delivered to providers and patients, or to impact patient care. And also the fact that we really have to think about workflow integrations. Yes. And so maybe
Somebody wants to comment.
someone wants to know about workflow integrations.
I just want to make a comment about this issue of productizing, because there are lots of great inventors and they come up with this amazing solution. But this question remains, okay, do you want to be a supplier? Are you going to hand your algorithm over to my team and then we run it, and then if things need to be fine-tuned or tweaked, are we responsible now for running it? Does the inventor become the vendor? And what is the right mechanism for the inventor to transform their lab into that vendor supplier? Because that's where applications die or scale. And when you get feedback about the application, who decides if it changes, right? So this, I think, is what Rohan is alluding to, is there's so much more in running an enterprise product beyond the underlying invention. It's all of the usability features that determine whether people run to it or run away from it. I mean, that's the experience with Abridge, our ambient documentation software. Everybody runs toward it. Our problem now is just too many requests for customization. It's not like, what is this thing? But we have a vendor. If, God forbid, we had invented that, we would do nothing all day except work on that product. So I think that's a fundamental existential issue for inventors.
Yes.
Do you want to become like a vendor and a company, or do you want to stay in a university and keep coming up with great ideas? You have to figure out where to draw that line.
So we are talking about two internally developed algorithms that are being translated to make clinical impact. But as you mentioned, Rohan, Insight AI is a company. And so creating products, and Richa, I'm sure that is, the anticipated next step in terms of how do you get that out into to the masses. When we think about that context in terms of moving beyond Yale New Haven Health, how would a product like this move from one health system to the next? Adam, do you have thoughts in terms of how they could take these innovations to Brown Health or other health systems, or what that process would look like?
Yes, I think they're well on their way, so congratulations, both of you. And I do think the challenge is, as you go to each health system, it's a cycle, right? It's a sales cycle. So you've got to kind of do the same process you did to start all over again, right? You've got to pitch your idea. You've got to figure out if there's a fit. And then the health system has to figure out if there's a funding model for it and an ROI. And then you've got to go through that implementation journey. So I do think this raises, I want to kind of build on Lee's comments a little bit in this. This raises a larger question, particularly around AI algorithms, which is there's only so many unique AI algorithm companies that an organization can engage, right? Like, these are wonderful ideas. There's probably another 100, right? And so those are each 100 conversations about trying to sell a product, implement, integrate a product, do a security review on all of that. Sign a contract. These are non-trivial tasks that take months and significant resources. And so this question of, is it a product or is it sort of a feature in a product, right? I do think there's going to be, at some point, right, we're at a stage in AI innovation where we need these point solutions that are outstanding. But I think at some point there needs to be some pulling together into platforms so that you could purchase, and much like you're working on an ECG platform, where you're getting a whole bunch of, which I know you're working on, a whole bunch of AI algorithms, you could see that at the ECG, cardiology. You could see it at the cardiology level. Maybe you do ECG and echocardiogram and CT angio. Maybe you see it across all healthcare, right? So I just think there's a practicality to how many products and companies can we engage with.
Right. Even if they're great, I'm not going to sign 100 AI contracts. Even if the price for each contract was reasonable, the cost of managing a contract is not the licensing cost. There is an overhead and a human cost of managing all those contracts, keeping them up to date, renewing those contracts, getting whatever addendums you come up with as the field evolves for privacy and security. It's too much to manage. So I agree with Adam. I'm going to go with a good enough vendor that has 20 products. Then I'm going to go with 20 different vendors, each with with an exceptional product.
So I'm noticing we're at time. So just to close out our session, Richa and Rohan, if you were to start all over today, what piece of advice would you have for innovators?
I think having the long view, that it's a lot longer of a journey than just creating your model, but also having a view of how you're going to get your product, for lack of a better word, to scale, making sure what you develop is interoperable, that you think beyond just a single health system, a single electronic medical record system. Make sure that it's agnostic at least, or deployable in an enterprise that reaches as much of the swath of the population that you're intending to help as possible.
Thank you.
I mean, I think I cannot echo enough. I just would say that build something useful and build something that scales, and I think that'll work.
Thank you to the panelists. Thank you all for joining the session. I invite you all to chat a little bit more with all of our panelists at the networking session that Yale New Haven Health is holding the reception at 2:30, and for you all to stay on for the 2026 Yale New Haven Health Innovation Awards ceremony, which is following the session right now. Thank you.
Congrats on the great work.
I'm sure. Just great panel. I love the phone job. That was there should be another slide now. Okay, stay right there. I was touching. So how did you get to that slide? Yeah, I just all right. So I don't know the slide, so I just want to get that talking through. I'm putting Brad in the
Generally, it doesn't matter. It's just good afternoon. Is that live? I don't think it's live.
Just one more thing, so this is the audio mic.
Perfect. Thank you very much. Great. Thank you, everyone, for sticking around with us here. We're really excited to share with you the announcement related to the awards associated with this very prestigious event. So thank you for sticking around. My name is Mike Angelini. I am the Yale New Haven Health System Treasurer and Chief Investment Officer, and I'm privileged enough to be part of the Center for Healthcare Innovation team, and glad to be presenting to you today. Along with me presenting awards this afternoon, I want to introduce three individuals who will come up in a few moments, and help us distribute the awards themselves. But I'll quickly introduce Pam Sutton-Wallace, the health system's president. Next to her is Arnhem Dantes, the system's chief financial officer. And then lastly, but not least, is Dr. Lee Schwam, who is the chief digital health officer for digital strategy and transformation here at the health system as well. So thank you all for joining all of us today. And we will get right into it. So obviously, a number of you have been around for the last 2 days joining us for the AI Symposium, and we appreciate your participation. And for those who did participate in the competition, we certainly appreciate that. As we know, we've heard from several multidisciplinary teams over the past couple of days. And those ideas that we heard, as we heard a few moments ago, were all grounded in real clinical needs. These finalists presented not only innovation, but practical solutions with potential not only to scale, but to provide real clinical solutions for our patients. Which as I recall, was exactly the health system and the university's expectation back in 2016 when CHI, the Center for Healthcare Innovation, was created. And so we're seeing that innovation, that vision come to play. We did have an expert panel join us, and you can see the judging criteria above, hopefully, which was unmet need, technical feasibility, novelty, as well as scalability and sustainability, and then lastly, team composition and skills. As you would imagine, we had very, very strong competition, fighting for $250,000 in awards this year. And we saw very clear themes across, of course, the rise in AI, workflow redesign, and new models of care. What stands out most was the focus on improving access, reducing friction for our clinicians, and delivering better outcomes for our patients. I want to take a moment and just acknowledge the fact that it was this composition of teams coming together that represents change that is both lasting and significant for the health system, and we want to recognize that. In a minute, we'll recognize the 3 award levels and all of the teams, but I want to ask the finalists in the room if you wouldn't mind standing.
Stand up.
Great. And I think that, thank you again for your contributions. And as I said, we'll be awarding at the bronze, silver, and gold levels, recognizing each one of those awards represent an increasingly opportunistic level of impact, readiness, and potential to scale. And so with that, we will move to the gold awards. And I will ask Pam Sutton-Wallace to join me for a presentation of those awards.
Yeah. You want to do it the other way around? Want to do bronze first?
Clearly not acting.
If you couldn't tell, I was following the script that was given to me. I don't know, I think we're going to go gold first.
All right, go for the gold.
Go for the gold.
Starting off with our first gold award, if I do this right. NeuroPro. Is Hinton here to accept the award?
He's lost it. He's running on the way here.
He thought you were doing bronze first.
Always with the last word, Dr. Schwab. So our next gold award goes to Enrich Health.
That, and then we also have a check here. We can't actually cash this one.
Go, Monique.
Front.
Okay, fantastic.
Right here, go ahead. Don't move. 2 more, 1 thing.
Congratulations.
And then moving back, our gold winner.
Look at that. Nice to be late.
Just in time.
Congratulations to our gold winners. Now we'll move into the silver category. ECG, OMI.